and introduce yourself?
Sorry, there was some noise. What did you say, Pan? Introduction?
Yeah, could you please introduce yourself, Gabriel?
Yes, my name is Gabriel. I'm a consultant surgeon in Helsingborg, which is in the south of Sweden. I do trauma surgery and endoscopy, including ERCP, and my PhD is about developing and evaluating a kind of tool to facilitate and standardize closure of the abdomen after open surgery. And I'm here as partly as the founder of this company. Thanks.
Thank you, Gabriel. Pelle, would you please introduce yourself?
Yes, thank you. My name is Per Nilsson. I'm a colorectal surgeon at Karolinska University Hospital, and I'm also an associate professor at Karolinska Institutet. I work with colorectal surgery, a lot open surgery for locally advanced disease. I also do HIPIC surgery, so a lot of large abdominal incisions on my part.
Thank you very much. And before we jump into the topics that we prepared for today, I just want to say a few words about Suturing. Suturing is a development company, a medtech startup. We are looking into developing and eventually launch a technology to facilitate abdominal wall closure and reduce the risk of incisional hernias. We're based in southern part of Sweden, in Lund, in Medical Village, which is obviously a hub for these type of companies. Great, thank you. Let me share some slides here. Just give me a second. So I hope you can see my slides. This is the panel, and as I mentioned, unfortunately, Matthias cannot be with us today, but he sends his regards. We're going to move into the first topic of the day, the first question of the day. So let's start the discussion. So Gabriel and Pelle, so abdominal wall closure, it's obviously something that is a big part of surgery in general. But could you explain a little bit for the audience how it affects your daily practice and what type of conversations, what type of guidelines you are applying in your respective clinic? If we could start with you, Pelle.
Thank you. Well, the last part of your question is really interesting because I think we're all aware of the importance of abdominal wall closure, but maybe we don't pay the appropriate attention to that detail. And I think that if you do large laparotomies and long operations, then at the end of the operation you might be tired, and I think that as I said, we do not pay enough attention to that detail. There's a risk for not doing it as one should, although you have the knowledge on how to do it. So it does affect you because it's at the end of the operation when you want to finish and you want to close up just and go home. So it does affect you.
And Pelle, you've been an active. Sorry, Pelle, you've been an active surgeon for some number of years now. How would you say that this topic, this area, has been, over the years? Has there been a trend in any direction?
Yes, there has absolutely been a trend. I mean, for many years, it was considered not very interesting, but then they, as you all know, they did the the extremely good and pioneering work in Sundsvall with how to actually close the abdomen to reduce risks. And I think that has influenced us all across, definitely across Sweden, but I think actually worldwide or globally, it has affected practice. And that was extremely important work. We have also, I mean, over the years, we have had different types of needles. We had some of you remember the double loop suture thing that was very, very popular for many years, but has disappeared now. And so definitely there have been changes over the past decades.
Great, thank you. So I turn to you, Gabriel. In your daily practice and in Helsingborg, how does it affect the situation in your daily routine in Helsingborg around the proper and correct abdominal wall closure?
Yeah, it affects us in many ways. It gives you a lot of bad conscience. But for instance, if you're on call and you do surgery within late at night, you suppose, because we know that the quality of suture is affected of many things. One of the things is that if registrars or residents are doing the closure themselves, you get worse quality. So there is important incitement that you are two persons closing the abdomen, and that one of them is responsible and consultant to make sure that you measure the quality of the closure, even if it's 3 o'clock in the morning. And I think another way that the closure quality affects us is that we still have not a big number, but we have a number of incisional hernias and the complications to incisional hernias that so we have to do emergency surgery for incarcerated bowel, which we really need to be aware of this problem, and we really need to lower the risks, and we can do that by ensuring a good closer quality.
And you mentioned risk, Gabriel, and I know, as not being a surgeon myself, but I know when I speak to surgeons, there's always this word that comes up around risk and risk assessment. So, what type of in your daily practice do you apply some type of risk assessment when it comes to abdominal wall closure based on the patient types? And would you mind elaborate a little bit on that, Gabriel?
No, I think we try to uphold a good closure quality for all patients, and as far as we know, the only guidelines that are applicable are the European Hernia and America's Hernia Societies that says that you should have small bites and a 4-to-1 closure ratio. So that's what we apply. But if you have a complication to the closure that you need to reoperate the patient within a week or two, then we apply other measures to reduce the risk of a new hernia.
Okay, great. Thank you very much, both of you. So I hear that you both are mentioning that there's a high level of evidence, both in terms of the number of studies around this topic, but also the evidence level around applying a good closure technique. And you, Pelle, you mentioned the study from Sundsvall, from Leif Israelsson, which is obviously a guiding study. But despite the number of evidence that is out there, there is, as we know, which is also confirmed in clinical studies, the compliance to the 4:1 ratio and the small bite technique is really not applied everywhere. Why is it like that? Why are we not? Let me see if I why are we not using the small bite technique as intended?
That
If
is,
we start with you, Pelle.
yeah, that is a very, very good question. I think there are several aspects to this. I think one is that it takes time to implement evidence, and I'm talking about decades sometimes. For instance, I mean, we knew that thrombosis prophylaxis was important for at least 10 years before it became routine. So that is one thing, implementation. And then I think also that we do tend, like Gabriel was mentioning, that we do tend to have, once the consultant has done the important and the high status part of the operation, you may leave the abdominal closure to a more junior colleague. And that is something that we should not do, but still, I'm sure and I know happens in various places, including where I work. So I think that we need to create more awareness about the importance of doing this, and that we as surgeons can actively reduce risks for incisional hernia and risk for complications. But I think it's awareness, and I think also that it's working on attitudes in part, which is often a very difficult thing.
One thing that I might be a controversial question, but I still want to put it out there, Pelle. Would you say that if there's a difference in the level of awareness between the different surgical specialties? Or is there one surgical specialty that applies the small bite technique more than another? I know it's a little bit controversial, but
yeah,
and we don't need to name specialties.
But I would say that obviously among surgeons who work a lot with hernia patients, the awareness is greater because they see the backside of poor abdominal closure. The ones who do not really work that much with hernia surgery may not have the same degree of awareness of the problem. So if you face the problem in your daily practice, I'm sure that your awareness of the importance of prophylaxis is greater.
Yeah, that makes sense. Absolutely.
That there may also be some differences if you were to talk. This is difficult to say, but if you are an obstetrician and the only, more or less, the only surgical intervention you do is cesarean sections, which is performed to a great deal in healthy young women with good healing capacity, maybe the awareness is lower because most of them heal well, whichever technique you use. This is speculation on my part, but
yeah, absolutely. From your perspective, Gabriel, I mean, you mentioned that this is part of your research, obviously. So we're very curious to hear about your perspective of why the small bite technique is not used as one could expect, maybe. So what's your analysis of this question, Gabriel?
I didn't look into this topic in my research, but there's a very nice, or actually two very nice papers, one from William Hope's group in 2019, where they, I think they sent out some 5,000 surveys to surgeons that were actually members of different hernia societies. And I think the answer rate was about 10%. Not much, but it's interesting because one of the questions in the survey is, why do you not apply the small bites technique? And there are some reasons. One is that it does not apply to my patient population. I don't know how to do it. 25% said, I don't know how to do it. And some 15% said it takes too long. And I think 1/4 said that they were concerned about closure-related complications if they applied this technique. So it's something about trusting the evidence, if you can call it evidence. There are a few randomized trials. I think there are 3 or 4 published randomized trials that show that if you apply the small bites technique, you can reduce the complication rate for both wound infections and incisional hernia about 50%. So this is very important. And about time, both the Stitch study from Holland and the Israelsson study, both randomized trials, showed that it took about 30% more time to use the small bites technique, and that is some 7, 8, or 9 minutes. And 7 or 8 or 9 minutes is a very low investment of time to reduce hernia with 50%, I think, at least.
Yeah, indeed. And yeah, thank you for that, Gabriel. Let me see here I just want to make sure we have the right slide. Just give me a second. Sorry. Yeah, and I was thinking about one question as I was running the video here, and either Pelle or Gabriel, if you want to comment on the suture technique here a little bit, because as we can see, and I think it's, if I'm not mistaken, Gabriel, it's you that are suturing. Is that correct?
It's a participant in our first trial. It's actually a vascular surgeon.
Okay. Thank you for that. No, I just wanted, because what we can see here from the video is that the surgeon is very particular and is paying a lot of attention to the right suture technique. At least from my not that very well trained eye, it seems like there's a 0.5 centimeter between each stitch, which indeed would lead to small bites. But we can also see that it takes a little bit of time. So Pelle, what do you think? Is this, when you see this suturing being done here, and the time it takes, is this something that you as a surgeon and your colleagues actively think about when closing? I know we've touched already on this topic a little bit, but knowing the time it takes, what's your perspective on that?
I think that it is not that difficult to, I mean, this is something that we talk about, the abdominal closure, because we do not want to have complications. We don't want to have the patient back with a hernia. It is like paying attention to how to do the stoma, for instance, because the stoma is very important for the patient. So it's not that difficult when you talk to colleagues or talk to yourself to find that it's reasonable and it's clever to spend those extra minutes in doing a nice and particular job, because you know that there are great earnings on the other side, so to say. So it is not a difficult topic to talk about, but sometimes it is difficult to implement what we all agree on, and that's because of I mean, you can do surgery in the middle of the night. You can have a long laparotomy of 6 hours and you're tired at the end of the operation and things like that. But that's when we need to encourage each other to do the job properly, because I think we know how to do the job properly, but we don't always do it.
We have a question here from, I'm going to pull up the question here from the chat. I have a few more questions, but so one question we have here: what is the additional considerations to avoid problems in case you have a second operation due to complications for the first closure? Yeah, Pelle, I see that you are considering to answer this question.
No, but I mean, if you have like post-operative wound adhesions on day 2, 3, I mean, that is very often it's a problem that occurs, and it's not, you're never happy about it. But I think the special consideration is that this can be detected in the middle of the night, and you should not just leave it to the junior doctor that is on call to do the second closure, because it can be even more difficult than the first closure. So this is something where you should encourage the more experienced colleagues to absolutely take part in this reclosure, so to say, because it's more difficult.
Since we're on the topic of complications and recurrences, I know there's an ongoing conversation when you go to the hernia meetings and so on about using prophylactic measures. I can see that Gable is raising his hand, so maybe I'll pause that question. Gable, did you have?
Yeah. We were talking about considerations if you have a complication. I think
please go ahead.
One of the most important things is to go back and look in the journal or in chart. And how did you perform this closure? Was the quality measured, or wasn't it measured? I think that's a very important lesson for the department, that you need to you really need to track what you're doing. And a pretty easy way to reduce complications to abdominal wall closure is to measure and register the ratio of the suture length and the wound length, the ratio. So that's an important consideration.
And to follow up on that, Gable, which is obviously an interesting statement, but in your world, in your perspective, how many do you think? I mean, you mentioned the research, but when you want to measure the amount of suture that you use for the wound closure, how often is that really done? I mean, does it depend on the type of patients, if it's a risk patient, or is it that someone applies it in a daily practice? Or would you like to comment on that, please?
I think if we go back to the HOPE paper from 2019, there were some 50% or 60% of the surgeons that replied the service that said they were using the small bites technique, but they didn't measure it. So maybe in that material, at least, it was 50%. And if you take the average surgeon and say, now you're supposed to close this abdomen, and you're supposed to reach the ratio of 4:1, then in some different studies, it has been shown that we reach good enough quality in 70% of the closures, which is not enough, of course.
But maybe we could use the participants, if we ask people to raise their hand, if they routinely measure the ratio when closing midline incisions. How many use it in their everyday practice? Then you can raise your hand.
We have a few raised hands here. I can see two. And let me see here. Not everyone participating in the webinar is a surgeon though, but we have two that raised their hands to that question, Pelle.
And I think that reflects, because when you talk to surgeons at meetings, you can see that there are some, in some departments, this has been really implemented and it's used routinely and everyone is taught to measure the ratio, whereas in many other departments, this is something that is not at all used, although everyone has heard about it, but it's still not used.
Yeah, indeed. But I mean, as I think it was Gabriel who mentioned it, but we do have as high rates of incisional hernia of 20%, which is a very, very high number, of course. It's one in 5. So even though we have an awareness or some type of understanding that small bite technique should be used, maybe not all of the surgeons will see the patients coming back with an incisional hernia, but we still have 20% complications related to the midline closure, which is obviously very, very high. How do we move forward from here? I mean, awareness is one thing. Applying something you've learned is another thing. So how do we move forward, really? Pelle, do you have any thoughts on that?
Well, I think what I hope is that, I mean, now in our country, there's a mandatory basic surgical skills course that you have to pass during your training, and I'm fully convinced that this is being taught, so that so we do have some hopes that it is gradually getting better. Then also I think that one could perhaps try to highlight in various registers that we have the rate of incisional hernias to and inform about it, and in that way, and I think that would also lead to an improvement.
Yeah, and I will turn to Gabriel to hear your perspective on how we can implement this best practice.
Yeah, my research supervisor, she usually says that it should be easy to do it correctly. If you have a method, it should be easy to follow the guidelines, and there are some things that makes it easier to perform a high quality closure. One thing is that when you enter the abdomen, you enter the abdomen precisely in the midline, and to do that you need to a little bit dissect the midline so you see what you're doing. And then another thing to make it easier is that you have a small needle. You shouldn't have a large needle. A small needle almost automatically makes the bite small, so that's important. And you need a simple way to measure your quality. And if you measure how much thread you did put in your wound, you have a very easy method of seeing if you apply to the guidelines or not. So that's important.
Yeah, we had a question in the chat that I will bring up here, which I think it's absolutely a valid question. If we know what to do, why is it not mandatory? A very straightforward, simple question. I know it's a complex area, but the question in itself has some appetite to it, I think. Yeah, Pelle?
It's a very good question, but I mean, I think everyone knows that it's not good to smoke. Still, some people smoke. So it's difficult. I mean, it's always difficult to implement change. I think all of us have seen these are the guidelines, but still we do not get 100% compliance to guidelines. So we are humans, and we are imperfect. I'm sorry.
And one thing that I thought about, sorry, what in surgical training for the residents, is there any specific training when it comes to the correct way of doing a midline closure? You know, Gabriel, do you know?
Pelle mentioned the course in basic surgical training. I think that that is one of the items that are taught in that course. But otherwise, most surgical skills are taught by your teacher that you work with for a number of years. And if your teacher is not interested in this topic, then maybe that's not highlighted. But another thing that is very important, that surgery there are maybe 100 different guidelines that you're supposed to follow for various things within the surgical curriculum. And this is just one of all those guidelines or important topics. So it's very easy to get that a topic gets forgotten in this jungle of different things that you have to learn.
Yeah.
I think.
Great, thank you. Yeah.
I think if I may also, I mean, what is happening in the surgical community is that minimally invasive surgery, robotic surgery, those are really the hot topics. And I think many of the young surgeons, they spend a lot of time learning and acquiring skills to become good robotic or laparoscopic surgeons. And there is a risk that you don't pay enough attention to all the details that are very important in so-called old-fashioned open surgery. So I think that there may be room for directed educational activities with regard to open surgery today, because it has changed over time, and I think focus is much more on robotic than on laparotomy.
Yeah, I think that's a very valid point. What we will do now, thank you very much, both Pelle and Gabriel, for your insights and your very clever answers. We really appreciate that. What we will do now is that we will open up for more questions from the audience, either if you put them in the chat or if you unmute yourself and ask them directly, that's also fine. So what I'll do, I'm going to stop sharing here so we can see each other. Give me a second here. And I'm going to figure this one out. But while I do that, so please pause here. There we go. Stop share. So while I do that, so anyone in the webinar who has a question or a comment, please feel free to do so. And let me see if I can have anyone here. No, not yet. Let me see. I had actually one here. So here's the question. Dr. Gabriel has said before that according to a survey across members of hernia societies, some surgeons hesitate to apply the small bite technique because they doubt their effectiveness. Why do they challenge this technique?
Shall I try to answer that?
Yeah, please.
But
I think it was directed
evidence in medicine is like any. It's not like even though you've published a paper, it's not like it's all that black and white. Some would say that I live in America and my patients are very big, and so the technique doesn't apply, or I didn't really like that paper due to some flaws in the statistics, and there is only 3 papers that support this, and some other papers support another side. So it's like any scientific discussion that you can always question it. But at least the small bites technique has found its way into the European Hernia Society guidelines, which is, I think that's what we should follow, because that's the only guidelines we have. It would be very interested. I see that Lars Nannestad is joining us. Maybe he can comment on that as well.
Yes, can you hear me?
Yeah, we hear you.
Yes, we can.
Okay, thank you. Well, I think I agree with very much what has been said, that different surgeons try to find different reasons why not implementing the results. From what I've seen from the Danish perspectives, the younger generation of surgeons really caught the message, and all of them, I would say, now adapt the technique, the small stitch, small bite techniques. We have more problems with especially non-general surgeons like urologists, vascular surgeons, still using big bites, some of them even with quickly resorbable sutures. Pretty awful.
Lars, maybe you should present yourself. Sorry, I missed that. But why do you think we have why is it so difficult to reach out to the urologists and gynecologists?
Well, perhaps it has to do with what kind of meetings we attend. They have their own meetings, so they haven't got the message from us general surgeons, who actually were the pioneers producing those results. And you just mentioned Israelsson, the Sundsvall experience. Later on, the Dutch demonstrated this in a multi-center trial. They just have not been confronted enough with this clinical and scientific evidence. I guess that's the reason why. So there's a great job for us to teach them, make them aware of the results. And actually, the investment in terms of extra 10 minutes really pays off for the patient, for sure, and society. But as has also been discussed here today, is the coffee time syndrome, that many surgeons, especially after long emergency procedures, perhaps lose the concentrations and do a poor job with the final closure of the patient after several hours of a procedure. That's one of the challenges.
Can I just say that Lars Nannestad is an expert in abdominal wall issues and was one of the presidents of the European Hernia Society meeting in Copenhagen last year.
Yeah, that's right.
Very nice to have you here, Lars. We appreciate that.
Thank you.
I mean,
I can see that.
if I may,
Sorry, Pelle, go ahead.
I'm sorry. With respect to the other surgical specialties, I think also that if you're a urologist, you don't take care of your own hernias. So this is, you sort of, the awareness of the problem is not as obvious as it is for a general surgeon working at so that is a threshold to overcome, to also to have them realize that these complications occur, even though someone else is taking care of it. I think that's part of the reason.
I agree.
Very interesting. We have, I see Andrea Stewart is raising her hand. So before I have some questions in the chat, but I'll pause them for now and I'll let Andrea comment.
Can you hear me? I'm not sure that my my phone is working correctly. Can you hear me speak?
We do hear you, absolutely.
Okay, so my name's Andrea Stewart. I'm a gynecologist, and I absolutely agree. I think it's a problem within our specialty. The first surgical procedure that one is taught is to do a cesarean section, and it's taught by obstetricians that do no other surgery than cesarean sections. So there's very little basic surgical training, how to enter and how to close the abdomen. So I think we have a problem within our specialty, and we're not as aware of the future risks after our surgical technique.
And out of curiosity, Andrea, because you are maybe representing a different specialty than the other speakers here, so yeah, how do you think to provide this, to spread this knowledge in the gynecological specialty, you know, do you have any thoughts on the best way to do that, or has it already been?
Yeah, I mean, I think that there's a difference between gynecological surgeons and obstetricians within our specialty. So I think that the surgical training could be organized in a different way, but I also think that gynecologists are not aware. I mean, we don't deal with our own. We mostly do a fun and steel incision, and surgery has evolved to minimally invasive surgery, and I don't think the general I can't speak. Gynecologic. I can't even say my own specialty, is aware of the risks. So I think we need to be better educated, basically.
So there's a education opportunity or training opportunity in specifically, you would say, in gynecology, right?
Yeah, at least within open surgery, I think so.
Yeah. Mm-hmm. Great. I'm going to turn to the chat. We had a question ago here, so I'm going to read it out loud. Is there any difference in hernia incidence depending on used suture material and size of needle? Yeah, I'm going to turn to Gabriel and Pelle, but Lars, if you're willing to comment as well, please feel free.
Oh, for sure. There are old studies. There is an old meta-analysis in British Journal of Surgery many years ago where they were able already at that time to show benefits with either non-resorbable sutures or long-term resorbable sutures, being much more efficient against prevention of incisional hernias compared to quickly resorbable sutures. But there was a trade-off with permanent synthetic sutures in that it caused more chronic pain and suture sinus formation compared to slowly resorbable monofilamentous sutures. So that already demonstrated that one should go for slowly resorbable monofilamentous sutures for fascial closure. Size of needle, that has also been shown. I know that there has been animal studies on this showing a much higher breaking strength when you use a small needle. I think there is some evidence, but I think there is more evidence concerning the quality of the suture.
When about suture needle size, it's interesting to know that's how at least the 3 different randomized trials that exist: the Swedish, the Dutch, and there's a German trial also. When they randomize between small and large bites, they have used a small needle to assure that the stitch is actually a small stitch or a small bite. So one can maybe think that the size of the needle is important to make the small bite, but otherwise I don't think the width or the diameter of the actual needle is important, but it's important to put a small bite.
Agree.
Yeah, I would.
Great. I think, yeah, Pelle, go ahead,
agree
please.
with that also. I mean, a large needle, it tempts you to take larger bites. So it's a psychological component here also that is, of course, difficult to measure. But I'm quite sure that that it's of importance that you try to use a smaller needle and slowly resorbable sutures.
I think Israelson originally said that if you use the big needle, you will also incorporate subcutaneous tissue and peritoneum to a larger extent in your suture. And the suture will cut through that material and create a very early diastasis, compared to if you only use the small needle that allows you only to grab the edges of the aponeurosis.
Very interesting. I'm going to turn to a question in the chat, which I personally find very interesting. In which high-risk group would you advise prophylactical mesh? If any, I would say. But it's a very interesting question. Pelle, do you have any thoughts on this?
Well, I mean, I may be considered conservative, but I think one should try to avoid meshes when one can. I'm not a fan of using more artificial material than necessary. So I would be very hesitant to use a prophylactic mesh if I hadn't resected part of the abdominal wall or something like that.
I could add that the studies are, as far as I know, mainly on patients undergoing repair of an abdominal aortic aneurysm. And we know that this specific population has a very, very high rate of incisional hernia, perhaps because of some connective tissue disease. I can follow what was just said, that it has not been widely demonstrated for other surgical procedures. There's still a lot of discussion going on whether you should use a prophylactic mesh when you create a permanent stoma. That had some very positive results until a few years ago, and now there's been some conflicting studies. So I think there is still a lot of disagreement in this field, except for the population of patients undergoing open repair of a AAA.
Indeed. Yeah, I would agree. There's always a little bit of controversy around implanting material, where you can always have some type of foreign body reaction. So, yeah. One last question, I think, and this is obviously also a very interesting question. Does the size of the incision influence the preferred thickness of the suture? Yeah, I can see Lars unmuted himself as well.
Oh, yeah.
So please go ahead.
I shouldn't say everything here, but in our institution, we adopted the Israelson technique many years ago and use a 2-0 continuous suture on a small needle. And that's definitely enough because the tension is distributed on so many stitches. So it's not the suture fracturing. It will cut through the tissue before it fractures, I would say.
Yeah.
I can just add that there's another paper, I think it's from Hope's group in North Carolina, that they saw an increase of incisional hernia development with the length of the incision. So if you have a long incision, it's a higher rate of incisional hernia. But I don't think there's a reason to use a thicker suture. But the nice thing is that most small needle 2.0 sutures are pretty short. I think they are 70 or 90 centimeters. So then you can do parts of the incision and then you make a knot and etc. So, but there's no reason to use a thicker thread.
Yeah, you're right. There is a German suture, though, from a German company, more than 150 centimeters. So it allows you just to use one suture for the entire wound.
Mm-hmm. No company mentioned here, Lars. Great, thank you. I think we're about to conclude, but before I do, I just want to allow if there's anyone either from the panel, Gabriel, Pelle, or anyone else in the audience who wants to summarize and say a few words before I do. Pelle, any concluding words from your side?
No, I just want to repeat, I think that Gabriel said something that is very clever earlier, that when it applies to all of open surgery. If you do one part in the correct way, you make the next part more easy. So if you pay attention to how you do your abdominal incision and you do it correctly, you do it nicely, then you've made it more easy for yourself to close it at the end of the operation. So it all fits together, and this goes for how to construct your anastomosis. Also, if you divide your bowel ends in a proper and a clever way, you make your anastomosis better and you reduce your risk of anastomotic leakage. So surgery is not only in the hand, it's more in the brain. So I think Gabriel said something clever about opening the abdomen.
Great, thank you. And since more or less Pelle handed the word to you, Gabriel, do you want to say any concluding words?
No, I think this was a very nice way to discuss these issues, an important issue, and I hope we can have some more webinars. And I'm very happy that we got the discussion going.
Me too, indeed, and absolutely. And I want to summarize by saying that even though, as both has been mentioned here a couple of times today, that the minimal invasive surgery has obviously been developing quite tremendously the last decades. And now we're seeing the rapid introduction of the robotic surgery. When we from Suturing, we visit different congresses, it's very clear that this topic around closing the abdomen is still very important, because there are still a large number of procedures being done open. And I don't think I'm too controversial when I'm saying that that's most likely to be the future for many years still to come. So this topic is indeed very interesting, and that's part of the reason why Gabriel has invested time and effort in this research and the purpose of this company, Suturing. So I want to say thank you very much for spending time with us this December afternoon, and we hope you found it valuable, and we're really, really thankful for your participation. So I wish you a great evening, and hope to see you again soon. Thank you very much. Bye-bye. Take care.
Thank you. Merry
Thank you.
Christmas to everyone.
Bye.